Good evening, ladies and gentlemen. Welcome to the trial session with First Aid AMC course. My name is Rabia, and I'm one of the tutors associated with First Aid AMC course. Let's just wait a couple of more minutes before maximum number of participants can join, and then I'll give a brief introduction about the course. And following that, we'll do a simple question solvation. Good evening, Dr. Suman and Dr. Lima. How are you guys? All righty. Well, it's good to see you all. There's just a couple of more people joining, and then we'll start with a brief introduction about the course, what we usually do in that, and what you are going to gain with it if you are going to join us. Good evening, Dr. Era and Dr. I'm sorry, I'm unable to say your name, but good evening. Good evening, Dr. Prakash. It's good to see you as well. Okay. Today I will be discussing one of the sample questions from this year, 2024, and I'll be pointing out the ways to solve the MCQ for the AMC CAT exam. And then we'll go through the questions and I'll help you get an idea about what we do in the sample question solvation classes associated with the First Aid AMC. Now, a brief introduction about the course. It's a 5 months course. Usually we take 3 to 4 classes per week. There are going to be 4 mentors, 4 or 5 mentors that you're going to be coming across if you're going to be joining with us. I'm one of the mentors that is going to take the sample question solvation classes along with the other 2. But the main course coordinator is Dr. Arshan, and he will be taking maximum classes in a week. So we divide the classes into, there's a theoretical class, which will be taken by Dr. Arshan. And then there are sample question classes, which will be taken by me and 3 other coordinators. In the theoretical class, we go subject-wise, like medicine, including respiratory, cardiovascular, GIT, elderly population, obs-gynae, surgery, pediatrics, population health, ethics, statistics, everything is covered in the theoretical class, whereas in sample question classes, we usually go through the exam questions and help you guys get equipped with the ways to quickly solve the questions and how to pick a correct answer among them. Now, a couple of things about the course. We are the course that is associated with maximum percentage of the people passing their exam. So our yield is quite high in the students who join our course. They pass their exam, and we have approximately 85% to 90% of the students passing the exam in the first go. Number 2 is that once you have done with the course, you do have the access to the recordings and the videos and the sample questions for a period of time. And there is also, once you finish the course, if you want to join the recall session course as well, that option is also available to you. Now, we are quite flexible, and we do try to help each and every one of you with all of the queries. So the course that we use the resources from, we go through the main book, which is John Murtagh. Latest edition is either 8th or 9th, with the soft copy of which will be provided by the course coordinator when you join our course. The other one is that handbook, which we all recommend all of you to go through. AMC has a handbook that has systemized questions and then mixed questions given there. We in the course don't go through the handbook, but there are some questions that are coming in the exam which are exactly the same as those given in the handbooks, but so we do point it out to you guys. Excuse me. And then there are guidelines which we take from a number of websites. So there is RECGP for the general practitioner, there is RCH, there is New South Wales Emergency Guideline, there is SA Health, Obs and Gynae guidelines. Also, there is for psychiatric as well, RANSCOG guidelines, and for and STI guidelines from the Australian Health Book. So we always recommend you guys to go through the handbook. It helps you build the concept because they have given the details about answers in much, the answers are given in much detail, and it also helps to get a good grip of the questions. Yes, therapeutic guidelines are also recommended. Every year, Dr. Ayman, there's a new edition of the John Murtagh because the guidelines gets updated. So every year there is a new edition, and we try to get the soft copy across to you guys. All right. Is there any other questions before we start our session today? RANSCOG. So if you type in the Google search bar any topic of the psychiatry and just write Australian, New Zealand guidelines, then there will be a RANSCOG. The guidelines will be available in the form of PDF. There is whole articles written on them, so you'll be able to access that. Alrighty, so there, I believe we should start our class today. So in the recordings, just give me a second, guys. I haven't removed the answers from the questions. So in the questions that we do, the reference guideline link is provided. So once you join the course, you will be able to access the soft copy from the software. And from there, you'll be able to click on the link and go towards the resource that we have used to answer your question. It's up to you, Dr. Prakash, whether you want to read the handbook before or after, but I always recommend that read the handbook before so that even if you don't have time afterwards, you don't waste your time in going through it again. So side by side, read it, do at least 10 to 15 questions every day, make a target of that. And eventually, because it's a big book, eventually you'll go through each and every question. And I do recommend to go through the whole handbook because much of your topics can be covered from there. And once you're going through the theoretical class, you will be able to recall which topic you have covered in the handbook, and you can just breeze through that. Look, there is no hard and fast rule which pattern AMC is going to follow, but they will give you a clear-cut information on their website if there is any change to the pattern of the question is made or not. So if there is any The class is still running. I'm just removing the answers. Sorry, the highlighted answers. Just give me a couple of seconds and we'll start our class. I'm just removing the highlighted answers. I forgot to do that before the class. You might have seen the first answers. This question answered anyway. Sorry about that. Alrighty, almost done. It's up to you. I would recommend if you join a course, 5 months plus 1 month for revision is enough to pass the exam. But if you have other commitments, you can take more time as well. Alrighty. Are you guys able to see the screen? In addition to the course, which MCQ question bank do you recommend? Go through everything you can. If you do have time, go through whatever you can. The maximum number of questions you do, the more grip you have over a topic. Alrighty. First question, whenever you're solving a question, always look at the key information given in the question, like age, sex, symptoms, vital signs, and what they are actually asking you in the last line. An old lady came to the emergency department with left acute ischemic limb, which is pale, cold, painful, and weakness. There is no femoral or dorsalis pedal pulsation on the left side. Right side of the limb is all okay. Her pulse is irregularly irregular. Which of the following is the initial step of management? Angiography, embolectomy, percutaneous thromboembolectomy, or percutaneous spray thrombolysis? So always remember, guys, if a patient is presenting with 6 Bs, which is pale, painful, pulselessness, perishing cold, paresthesia, and motor weakness, then we call that condition in a lower limb or an upper limb as acute limb ischemia, if it is presenting within a couple of hours setting. There is an important information they have given you that patient has atrial fibrillation, which is a risk factor for a patient to have acute limb ischemia if the patient is not properly anticoagulated. And right side of the patient is okay. So the first step is absolutely right. We want to do angiography. Why do we do angiography? Can anyone tell me? What's the purpose of doing angiography? To locate the blockage. Very good. Angiography, the purpose of it is that we insert a dye to one of the vessels and we basically do an X-ray of that limb and we can see on the monitor where the blockage is, whether it's a thrombus, whether it's an emboli. If it's a AF, then it's a embolus, which was a thrombus somewhere and then became an emboli and obstructed the flow of the blood to the lower limb. Now, the best of, if the question is changed and they ask you which one of the following is the best step of management, then what would be your answer? What is the best step of management? Very good. So the best step of management for acute limb ischemia is revascularization, which is to remove the clot so that we can make sure there is blood flow to the limb. So embolectomy is the best step of management. Excellent. Now, to support the answer, you guys can go through the New South Wales guideline. It's very well written for lower limb ischemia. Just open it up. Alrighty. Are you guys able to see the screen? Acute Limb Ischemia Emergency Care Institute, New South Wales. Embolectomy is not going to help you locate the blockage. Embolectomy basically means that you're removing the blockage. To locate the blockage, we need to do angiography, which is a procedure in which you introduce a dye into the vessel and take radiographic images of it. That helps you to localize where there is a blockage in the vessel flow. The next best step about the acute limb ischemia is to remove the blockage, which is embolectomy. You can do both procedures side by side. Usually they are done side by side. You do angiography followed by embolectomy. Alrighty. Acute limb ischemia, as I said, is a sudden decrease in limb perfusion that causes critical threat to limb viability. There are certain risk factors to it, like atrial fibrillation, recent myocardial infarction, aortic atherosclerosis. Doesn't matter if it's in aorta, it could be anywhere else. Large vessel aneurysmal diseases or a dissection as well. Lower excrement, you had previous history of angioplasty, stenting, or bypass grafting done in your lower limb before, or a patient had acute limb ischemia before. There is trauma to the arteries, or there is a DVT. Sometimes paradoxical embolism can go from the DVT into the heart and then back into the arteries and cause blockage in the lower limb. So if the patient presents with 6 Ps, which is pain, pallor, pulselessness, perishing cold, paresthesia, and paralysis, always think about acute limb ischemia. And this is a very acute emergency condition. You need to be very much having a high suspicion for acute limb ischemia, because there's a certain time period in which we can actually reverse the effect of the ischemia. If we are past that time period, then the limb becomes non-viable. All right, focused assessment, how you can do, you can do a focused history and examination. In examination, you can look for the 6 Ps, especially, so pulse, there are grading mechanisms as well. So what we need to do in these patients is a ECG as well. So as I said before, atrial fibrillation is a very, very, very high risk factor for a patient to develop acute limb ischemia. So always after doing a focused physical examination and history, start with your ECG to look for atrial fibrillation. Then you do the basic blood tests like full blood count, electrolytes, urea, creatinine, coagulation, very important. Creatine kinase, lactate level, because it can help you assess the degree of hypoperfusion of the tissue. So if lactate level is high, you do know that the injury to the lower limb is causing a lot of ischemia. And we want a vascular surgeon opinion as soon as possible. So how do we assess whether the limb is viable or not? We also get a use of the bedside Doppler ultrasound as well, that help us to, because sometimes you can't find the pulse, but it's there. So Doppler ultrasound will give you a good idea about whether pulsations are diminished or not. So viable limb is there is no immediate threatening, there is no sensory loss or weakness, there is arterial Doppler signals, and urgent workup is indicated in that. Marginally threatened means that there is sensory loss, mild, but no weakness, and there is inaudible arterial Doppler, meaning there is diminished pulses or obstructed pulses. Immediately threatened, you will have more paresthesia and motor involvement, and you can see that the patient is developing rest pain, and Doppler again is going to be inaudible. Irreversible, you can actually see patient is unable to feel any sensations, and patient is having paralysis. And in this manner, you can see the limb is actually getting cold, and there's signs of its gangrene developing in the limb as well. So in this case, to prevent the further progression of the disease, we do amputation. Serum lactate indicates hypoperfusion. So if it's high, it means there is a high level of ischemia going on. In atrial fibrillation, warfarin given only if valvular AF? Not necessarily. If there is a mechanical valve involved, then yes, we do give warfarin in those cases. DOACs is preferred for non-valvular AF. That's absolutely correct. Okay, so you can start with Doppler ultrasonography at the bedside to get the arterial signals. But the best initial one is that you do a CT angiography in the emergency department in the imaging, or you take the patient to the OT. Once there is a high level of suspicion, you do angiography in the OT, performed along with the embolectomy or a bypass surgery if required, depending upon the vascular surgeon. Okay. Meanwhile, when you're doing these two, what you can do is that you can start the patient on IV fluids, make sure that the patient is nil by mouth because this patient will be requiring surgery. Make sure patient is pain-free and start the patient on anticoagulant, which is IV heparin. Unfractioned heparin or low molecular weight heparin, depending upon patient's symptoms or the availability of the drug, you will decide on that. Treatment of the non-viable limb is amputation. Is it clear, guys? Any questions from here? Did you see how we proceed step by step? So if they have mentioned that the patient is getting hemodynamically stable, instead of going for angiography and doing an embolectomy, we will resuscitate and make sure patient is vitally stable to survive anesthesia for the procedure. So make sure that the patient is hemodynamically stable before you opt for any of the procedures or any of the imaging, okay? Next question. There is an old lady who had an hysterectomy 15 years ago, a very big clue. She came with 2-day history of colicky abdominal pain, and she has distension as well. Now her pain, which was colicky in nature, is becoming constant and constricting in nature. Vital signs are all still stable. What is your diagnosis? Is it a small bowel ischemia? Is it a bowel volvulus, or is it a small bowel obstruction with no ischemia? Very good. So it's very clearly mentioned in the question that the patient has previous surgery. Whenever a patient has previous surgery, the chances of the small bowel or the large bowel getting obstructed because of the adhesions is very high. Patient had colicky pain and then it's constant. This is very typical for small bowel obstruction. Vital signs are stable, meaning it's not, the obstruction is not bad to the point that is making the patient hemodynamically unstable. Okay, so diagnosis is small bowel obstruction with no ischemia. If there was ischemia, patient will have exaggerated pain response on examination. Plus, patient will not be vitally stable because small bowel ischemia is again associated with atrial fibrillation. So you will find something like irregular pulse or ECG, which is unstable, or they will give you a history that patient had AF and now developed this sort of symptoms. For sigmoid volvulus, always remember, they will give you a long-standing history of constipation because it's one of the risk factors. Number two, they will give you information because it's very common in institutionalized elderly patients who are bedbound or who have less physical activity or fiber in their diet. They are more prone to having a sigmoid volvulus. And volvulus will present with the large bowel obstruction, absolute constipation, distension, abdominal pain, followed by nausea and vomiting as well. Clear, guys? So in acute mesenteric ischemia, There will be sudden onset of poorly localized abdominal pain, especially after eating. Patient will report, oh, I have eaten my breakfast or lunch or dinner. And then afterwards, I started having this abdominal pain, followed by diarrhea. Sometimes they report having some blood in the diarrhea as well, and vomiting. And on examination, you will find pain out of proportion. So when you press down, patient will literally jump up because there is a high peritonitic reaction going on inside the abdomen. So the types is arterial, venous, or non-occlusive ischemia. So atherosclerotic heart disease, atrial fibrillation, valvular heart disease, recent MI. These are all the risk factors. And it will look like this. Pneumatosis, intestinalis, there will be air plus the bowel contents in the bowel. Whereas in the bowel obstruction, we all know there is mechanical causes, which can be because of the adhesions, which can be because of the neoplasms, and it can twist upon itself or telescope into itself, volvulus and intussusception. It can be because of the hernia as well. It can be because of the fecal impaction. It can be because of electrolytes derangement. It can be because of the inflammatory disorders like IBD. Any question, guys, from here? All right, let's move on. So always look for key information they have given in your question and what they're asking about in the last line. Let's look here. A child hurt his head while he was playing. No loss of consciousness, but slightly slow in activity. Right now he's playing. They're asking you what is the next most appropriate step. Would you ask him to stop playing? Would you stop him playing and observe him for the next 4 to 6 hours? Or would you transfer this patient to the hospital? Now, regarding the head injury, there are categories of it: mild, moderate, and severe. What category do you think this patient is falling into? Very good. It's a mild category. In a mild category, patient can have head injury, but there are no neurological signs. GCS is stable. Patient does not have focal neurological deficits. Patient doesn't have signs of raised intracranial pressure. There's nothing going on. So in such patients, because head injury can be very, very unpredictable, so always observe a pediatric age group patient or an adult patient as well for at least 4 to 6 hours post head injury, so that we can rule out if there is ongoing increased intracranial pressure or if there is something developing in the next 4 to 6 hours. It usually does. If there is an injury to the brain, or if there is a raised intracranial pressure post head trauma, it will manifest itself within the next 4 to 6 hours. That's why the first 4 to 6 hours are very, very crucial for you to observe the said person for these signs and symptoms. Very good. So we will observe him, and if the patient is clinically well, we'll give information or educate the parents about the red flags to look for and discharge him into the parents' care. This is the RCH guideline regarding the head injury management. All right, give me a second. Sorry, it's just taking a bit of time. All right. Are you guys able to see the screen? Okay, so whenever there is a head trauma, we do a primary survey and resuscitation in which we evaluate the airway, breathing, circulation, disability exposure of the patient and assess their GCS level, which is Glasgow Coma Scale, in which we assess the eye movements, the verbal response, and the motor response. If there is a mild head injury without the risk factors, then what are the risk factors? There is no headache, there is no altered level of consciousness, no neurological deficit. You don't suspect it's a child abuse. There is no palpable skull fracture on examination. There is no sign of base of skull fracture, which is recognized battle sign, leakage of CSF or blood from the nostrils or from the ear. There is no hematoma. There is no severe mechanism. There is no loss of consciousness, no vomiting. Patient does not have any bleeding disorder or is not on any anticoagulation. Patient doesn't have a neurological condition like a ventriculoperitoneal shunt for the raise for hydrocephalus, or there is no neurodevelopmental disability. For example, in a cerebral palsy patient or in a patient with sometimes Down syndrome as well. If everything is fine, you do a secondary survey to assess for other injuries and discharge the patient. In mild head injury with other risk factors, meaning patient is complaining of some drop to the GCS, like in our patient, he was a bit slow as compared to before. So we will observe him for 4 to 6 hours. And if patient is consistently okay, then we don't need to do further anything. We'll just discharge him with the advice about what to look for. But if there is signs of developing risk factors within those 6 hours, then we will consult a neurosurgeon and order a head CT with the cervical spine CT as well. And we'll do the secondary survey. If there is a severe head injury, GCS of 3 to 8, it's a trauma emergency. So we need to follow a protocol here. Neurosurgical team will be involved, ICU team will be involved. Patient will be stabilized by intubating, making sure that they have given management to control the ICP level. And once the patient has been stabilized, we'll do an urgent CT head with a cervical spine. Glasgow Coma Scale, we all know about this. History is very important. Examination, neurological examination. Investigation is the CT scan. Management for persistent, moderate head injury or severe head injury, especially for the ICP, is oxygenation, ventilation, circulation, and to avoid the rise in the intracranial pressure. Very, very important, guys. Is it clear? Any question? Clear. Okay. Let's move on to the next question. 45-year-old man presents with prostate cancer with invasion of the seminal vesicles. You do an MRI, there's no metastasis. PSA level is 55. What is the most appropriate treatment for this patient? Would you do an external beam radiotherapy? Would you do a radical prostatectomy? Or would you do an androgen deprivation therapy? Okay. To help you guys, because this is a difficult question, First, you need to know about the stages of the cancer and their treatment appropriately. Let me just show you one of this that can help you guys in solving this question. Can anyone tell me what's the stage of the prostate cancer? Very good. It's stage 3B. Let me just put this here so that you guys can take a picture as well. All right, are you able to see this chart? This is for your information. So this is stage 3B. It's spread to the seminal vesicles, the glands on each side of the bladder. Now move on to this one. This is the cancer guideline for treatment of the prostate cancer. So prostate cancers are very unlikely to grow. Very low risk groups are those in which the prostate cancer is within the capsule, or it's you can't evaluate the tumor, but there is only high PSA level, or the tumor was not detected during a DRE or other imaging study, again supported by the PSA level, or tumor is of T2A, T2B, which is in one of the lobes of the prostate, in both lobes of the prostate. These are the patients who have, which are the very low risk group. So what we do in them, if there is just high PSA level and you can't detect the tumor on examination and imaging, we do active surveillance for them. We look at the comorbidities that can shorten their lifespan, and we determine from there onwards what course of treatment should be offered to them. So if they're like 85-year-old who has a high PSA level with heart failure, COPD, uncontrolled diabetes, multiple infarctions, then in those patients, we don't usually do any treatment. We offer them surveillance if there is no active imaging that can find the cancer. Am I making myself clear, guys? So in any cancer, whenever you are treating something, we often correlate patients' comorbidities, their age, and their prognosis as well. So everything which I have discussed is called prognosis. We discuss about the prognostic factors of the patient, and on the basis of those prognosis, we do the disease management. So, oh, sorry. So men who are just not comfortable but have a good prognosis, undetectable disease, they're not comfortable with monitoring the cancer but choose the treatment. You can offer them either radiation therapy, which is external beam therapy, or brachytherapy, or radical surgery, which is radical prostatectomy. Most of the patients respond very well to radical prostatectomy. It's not a major operation. It's 30 minutes procedure and it has good outcomes in patient who has undetectable disease as well. Another thing that we can offer them if they don't want to go through the surgery or the radiation therapy is the cryotherapy as well. Plus, if the patient has any contraindications to surgery or radiation, or just surgery or cryotherapy, we can offer them a combination of the radiation therapy and hormone therapy. Because as you all know, prostate is a hormone-dependent organ. So once we ablate the hormones, the prostate cancer will be repressed or it doesn't go forward as well. We do hormone therapy and then we fry up the cancer tissue with the radiotherapy. Low risk groups are again T2 ones. You can offer them surgery or radiation therapy. Again, same things, active surveillance depending upon their comorbidities and everything. Now, intermediate risk ones are those who have T2B and T2C and T3 stages. And they have very favorable outcomes. So the cancers are slightly more likely to grow and spread or has grown and spread. So what we can offer them is, other than active surveillance, if they don't want it, you cannot offer them radical prostatectomy with the removal of the nearby lymph nodes, followed by radiation therapy or radiation therapy followed by surgery if you think that the tumor is of large size and cannot be operated effectively. Once the surgery is done, we can offer them hormonal therapy as well. Unfavorable intermediate risk groups are those in which, for example, T3B, which is likely to spread, which has spread to the seminal vesicles, but is likely to spread to the lymph nodes as well, or is going to spread to the other tissues as well. So our patient is the one who has intermediate risk group. So we will offer them surgery first, followed by external radiation therapy plus hormone therapy, because we are actively treating the disease now. Is it clear? High risk or very high risk groups are those in which there is metastasis. Metastasis requires radiation plus hormonal therapy before we can do radical surgery, because we know that the cancer is spread. We want to make sure we target as much of the cancer tissue as possible before removing as much cancer tissue out of the patient as possible. So active surveillance is depending upon the patient's age as well. If you have a patient who doesn't want any intervention, but just want active surveillance, it's done 3 monthly, 6 monthly, yearly, 2 yearly, based on the disease progression. If there's no progression, you can space the time. If there is a lot of progression, you need to cut down the surveillance times as well. So our patient in this question is the one that is having a intermediate risk disease. How it's intermediate? Because it's T3B, it's beyond the prostate, but it doesn't have any metastasis. So we will offer the patient radical surgery, followed by a combination of either external beam radiotherapy and hormonal therapy, or one of these two things. Is it clear? All right. Now there is something called Gleason score as well. I'm just putting here for your information. Once you go through the theory with us, we'll give you more information about what is Gleason score. But if you want to have a look, there is a scoring we do for the prostate cancer as well. through Gleason score, which is histologically associated. Okay, all righty. Oh, I'm parched. Okay, any question, guys? So always look at the question from a broader perspective whenever they are asking you about cancer. So look at the patient's age, look at the comorbidities, look at the stage of the cancer, and then you go accordingly to that. All righty. 50-year-old male with it's cancer.org.au. 50-year-old male is presenting to you with right shoulder pain for days, always complaining of restriction of abduction and pain in the shoulder, partially get benefited from the intra-articular steroid injection before. What to recommend him for the acute pain stage he is having in this moment as next? Number one, ask him to do physiotherapy to manage the pain. Give intra-articular steroid again. Give methotrexate or give regular paracetamol. Okay. So majority is answering between 1 and 2. This is a patient who is coming to you with acute pain. Basically is having either frozen shoulder or adhesive capsulitis, or the patient is having supraspinatus tendinopathy because there is complaint of restriction of obstruction and there's pain there. For pain, would you recommend physiotherapy? Or would you manage the pain first? What would you do as a doctor when the patient is coming to you saying, oh, I have pain? What would you do? Pain management first, right? Now, very important clue they have given you. Patient got partial benefit from intra-articular steroid before. What would you recommend for him as next? Would you recommend regular paracetamol or intra-articular steroid again? Very good, Dr. Darwin. So patient got benefit, even it was a partial benefit, he got benefit from intra-articular steroid. And them mentioning that the patient got benefit from steroid injection gives you information just in your mind that patient did not benefit from paracetamol, right? So regular paracetamol did not do anything. That's why he had the intra-articular steroid before. So once you give regular paracetamol, it might not help the patient. Give the patient intra-articular steroid again. You're very right, doctor. This patient, as he's having recurrent pain, needs to be evaluated not with MRI. First line should always be an ultrasound, followed by X-ray. Once the patient pathologies are ruled out from that, then you can move on to the MRI to assess whether there is any soft tissue injury going on as well. For shoulder tendons, ultrasound is also a good modality to give information whether there is any intra-articular tendinopathies, bursitis, or supraspinatus tendinopathy as well. Why are we giving steroid without any confirmation? Which confirmation about the disease? You can give intra-articular steroids after every 3 to 6 months. It's a local steroid. It's not a systemic steroid. It's just going to bring down the inflammation and make patient pain-free. You can give steroid without confirming the diagnosis. You can make sure the patient is pain-free, and then you can do the imaging as well. There's no hard and fast rule about you need to confirm before giving the steroid. It's not like that. It's also, you can do, there are a lot of physical examination signs, and there are certain examinations that you can do that can help you make a clear-cut diagnosis. We can give every 3 to 6 monthly, Dr. Frank. Once the patient is pain-free, you can try physiotherapy to prevent recurrent episodes. Does that make sense? Yes, I agree with you. So in a patient who is coming with musculoskeletal injuries, there are very clear-cut examination that we do that gives us a very good idea about what sort of injury is there. So if you go to this RACGP, shoulder injuries management in general practice, there are different types of it, like rotator cuff lesions, impingement, adhesive capsulitis. It can be instability of the intra-articular joint, osteoarthritis, or referred pain. Special test, very, very important. More than the imaging, we rely on this. So impingement syndrome, you can do, let's go directly towards the clinical assessment. This one, Hawkins test. You can define whether the patient is having impingement syndrome by doing this test, in which what we do is that we flex the elbow to 90 degrees and we then internally rotate the glenohumeral joint by placing our hand in front of it and pushing it down. If the patient complains of pain, a lot of pain, then we know that the tendon is being impinged under the acromioclavicular joint. These tests will help you make a narrow diagnosis. Similarly, for anterior shoulder instability, this test is done, which is called anterior release test. Rotator cuff, very, very important, especially in persons who have over the head abduction use. So drop arm test or emptying can test is very important for this. Acromioclavicular joint sprain or osteoarthritis, if the patient is just complaining of pain and is elderly or is a postmenopausal female complaining of pain just on movements and there is crepitus there, then you can do an X-ray of the joint and you can find there's osteopenia at the joint basis. So active compression you can do for ACG pathology as well. So with the exception of red flags, what are the red flags? Weight loss, fever, systemic signs and symptoms like lymph nodes, patient is having abnormal, disabled, or abnormal posturing. These are the red flags. Other than that, if the patient is just presenting with pain and restriction of movement, you can do clinical test, you can do investigations, and then you can do appropriate analgesia followed by early physiotherapy. Appropriate analgesia, we go step by step. Simple analgesia, then there is opioid-based analgesia, and then there is intra-articular steroids. Clear, guys? Sorry. Okay. Next question. A patient is working as a manager in a company, complaining of delay in the work, number 1. Studies postponed, number 2. Difficulty in organizing work, number 3. Poor concentration, number 4. All started after an event which happened 3 months ago. What do you look for out of A, B, C, D to support your diagnosis? Option A, increased forgetfulness. Option B, anxious and fidgety. Option C, impaired memory and concentration. Or option D, difficulty in organizing tasks and postpone activities. Okay. Let's forget everything and just look at the second line. Everything started before 3 months. So we know there is a trigger. If there is a trigger and it's associated with the social and work life problems, especially delay in the work, postponing of the studies, difficulty organizing, poor concentration, then we need to look for something associated with the trigger. Now, whenever there is a trigger, always think of two things. Either it's a psychosis or it's an anxiety-related disorder. So if there is a psychosis, you need to look for whether there is hallucination, delusion, speech, or behavior problems. If there is nothing like that mentioned in the question, then look for anxiety symptoms. Which one of the following is your answer now? Very good. B. If there is anxious and fidgety appearance associated with delay work, studies, postpone difficulties organizing work, poor concentration, and it all started after or before 3 months. It's not an adjustment disorder. It's a stress disorder or anxiety disorder. It can either be acute stress reaction or it can be a PTSD as well. So we don't know which we know there is a trigger and we know that the patient has social plus behavioral symptoms. As I said before, look for the trigger. They have given you a clear-cut line. All started after an event. There is a trigger. Those two things should always come into your mind. It's either a trigger that has caused patient to develop psychosis, or it's a trigger that caused patient to develop anxiety-related disorder. So this is most likely an anxiety-related disorder, either acute stress reaction or PTSD, but because of the timeline, most likely PTSD. Wilson's. It can be Wilson's, but in Wilson's, they need to give you a focal neurological symptom or an abdominal hepatobiliary symptom or a skin symptom. Or they can mention that there is paternal family, somebody has the same symptoms or somebody died because of this. Or they can mention that there is something in the eye, like Gescher-Fletcher rings. They can make an ambiguous mention of that. If there is nothing physical symptom like neurological, GI, hepatobiliary related, skin related, or the eye related one, or the family history mentioned, don't think it's a Wilson's disease. So acute stress disorder, PTSD, both are anxiety-related disorder. The difference is just the time period. So if it's occurring within 4 weeks of the event and lasts for minimum of 2 days or maximum of 4 weeks, it's a acute stress disorder. But if it's if it's happened within 3 months of the event or 3 months to 6 months of the event, then it's the PTSD. Symptoms are all the same. Numbness, detachment, things seems unreal, amnesia, relieving avoidance, anxiety or increased arousal, distress and social or occupational impairment. These are all the symptoms of the anxiety-related stress or PTSD disorder. All right. Any question, guys? All right. It's not necessary, Dr. Mayawat. Patient should always have nightmare flashback, not necessarily. Patient will exhibit more social symptoms. But if they mention nightmares or flashback, then it is definitely PTSD, but not always. They will not always give you nightmare or flashback. They will give you either, oh, accident happened, or acute stress event happened 3 months ago, and patient is having socio-economical, socio-occupational symptoms associated with some physical symptoms. Might not mention nightmare or flashback, but think about anxiety disorder if there is no psychosis. Okay. Question. Old man with a lot of medications has dizziness, number one, and had a syncopal episode. Syncopal episode, meaning there is a transient loss of consciousness. What should be stopped first in their medication if ECG shows a heart block? There you go. You have a heart block now on the ECG, which caused dizziness and syncope. Number one, digoxin. Number two, spironolactone. Number three, beta blocker. Number four, ACE inhibitor, or number five, a digoxin and spironolactone. Very good, everyone. So the first drug we stop if we have a heart block is beta blocker. So three drugs we need to stop whenever patient has a heart block. Which one of those are? Beta blocker, very good. Calcium channel blockers, very good, and digoxin. Okay, so if the patient is on all three of them, stop all three of them. If the patient is on two of them and you need to make a decision about which one to stop first, beta blocker is the first culprit you need to stop, okay? Because beta blocker makes the heart block worse, along with digoxin as well. So if the answer said, for example, A and C, then I want you to select this one instead of just beta blocker. But answer said A and B. Spironolactone doesn't cause any worsened effect in a patient of heart block. It's a heart failure medication, also has an effect of the diuretic as well. So digoxin and beta blocker should be stopped in a patient with the heart block. That is the first line treatment of the heart block, actually. If the patient is on digoxin, beta blocker, calcium channel blockers, stop these medication and review the patient again. Patient most of the time reverts back into sinus rhythm with the and the heart block resolves. Would we prefer stopping calcium channel blocker first or digoxin? Beta blocker, calcium channel blocker, digoxin. That's the way we go. We stop the beta blocker first, we stop the calcium channel blocker and digoxin. BCD, yes. But if they say like something like this, they have given you option in one of the options that stop all of them, please pick that option. That is the best option. We do stop all of them. Okay. There's a lot of articles that you can find evidence-based about the significance of stopping these medication in a complete heart block. Let me just increase the size. So NCBI says in third-degree heart block, common drug that causes, because third-degree heart block, it means that AV node is completely blocked, right? So P wave is not followed by a QRS complex. Dissociation is there. So we always stop the drugs that causes the AV block or worsens the AV block, like beta blockers, calcium channel blockers, any other antiarrhythmics that causes AV nodal blockade, and digoxin. Withdrawal of the offending drugs is the first line treatment. Patients who are having the block at the AV node in the absence of ischemia can benefit from sympathetomimetic agents or vagolytic agents. Vagolytic agents can be like adenosine. Medication that may be used in the management of third AV block include sympathetomimetic agents, vigolytic agents, and catecholamines. Examples of sympathetomimetic or vigolytic is atropine you can give if the patient is very, very bradycardic, or you can give isoprenaline to the patient as well. It can only be given in the ICU setting because it causes very low blood pressure as well. So this patient is also causes arrhythmia, other arrhythmias as well. So isoprenaline should always be given under strict monitoring. You need to be very much on high alert when you're giving isoprenaline infusion to the patient who was having bradycardia symptomatic or complete heart block. But the ultimate treatment of the complete heart block is a pacemaker. You need to insert a pacemaker into the patient because these patients who are having syncopal episodes, even after stopping the culprit agents, patient is not reverting back to the sinus rhythm. This is of very much concern. Patient can drop or have a syncopal episode anywhere and cause harm to himself or the surrounding people. So pacemaker in these patients, transcutaneous pacemaker or permanent pacemaker as soon as possible. All right, let's take a 5-minute break and then we'll come back and finish this class. 5 minutes break, guys. All right, guys, welcome back. Let's continue. Are you guys able to see the screen? All right. So the next question is, a patient presented to you with injury to left eye, but patient had previous history of cataract. Vision is decreased in the left eye, and in right, it's partially impaired. Patient describes gradual loss of the superior vision field. Which one of the following is the diagnosis? Option A, retinal detachment. Option B, vitreous hemorrhage. No, I did not miss any question. All right. Very good. So we know when there is gradual loss of superior vision field followed by the inferior vision field, like a curtain coming before the patient's eye after a trauma or an injury, that is more pathognomic for retinal detachment than a vitreous hemorrhage. Vitreous hemorrhage, there will be sudden painless loss of the vision. But in retinal detachment, they will describe the superior vision field is lost and then the inferior vision field is lost. Have a look over here, guys. In RSCGP, they have a very well sorry, I'm just trying to find where it is. Okay. Look at this one. This is how a vitreous hemorrhage looks on the fundoscopy. And this is how a retinal tear followed by retinal detachment looks on the fundoscopy. Patients with a retinal tear or a hole will develop a retinal detachment. Trauma is also associated with that. Most commonly, patient will complain of a shadow or curtain coming down, associated with floaters and flashes as well. So we need to take a history, we need to examine the eye, and direct ophthalmoscopy is not enough. So you need to do fundoscopy as well. So these patients who have retinal detachment needs a referral for ophthalmologist because they need proper treatment to overcome the sudden loss of vision associated with that. So there is another article with RSCGP regarding the sudden loss of vision and their risk factors. So with the retinal detachment, patient will have sudden loss of vision in seconds, with duration lasting minutes to indefinite, if not treated. So in detachment, there will be flashing lights, floating spots, curtain progressing from side of the visual field. If it's a superior visual hole, then they will describe curtain coming down the eye. That was the fundoscopy of the retinal detachment. Okay. Vitreous hemorrhage literally looks like hemorrhage. Can you please show the Medscape slide for hot block treatment? I can show you the slide so that you can have a look at the this one. Can you take a screenshot so that you'll be able to access that? Or you can just write NCBI and heart block. You'll be able to, the whole article will come up. Okay. An obstetric question now, guys. A whole turn of events. There is a cord prolapse. Fetal heart rate has dropped to 95. Patient is fully dilated and station is at +2. Which one of the following is the next step? Start maternal push down. Low section cesarean, or replace the cord in the vagina. So it's stage 2, fully dilated, patient with the cord prolapse. What do? Do we ask the mother to push down or we do assisted delivery? Very good. So the first thing we do is that we push the cord in the vagina with the finger. We ask the mother to stop pushing. We place her in knee to abdomen and make sure her pelvis is straightened up back. We call the emergency because this is going to be a multidisciplinary team management. As she is fully dilated and the baby is at station 2, we can't go for cesarean section, right? So this needs either forceps or suction cup delivery. And that is done by a trained obstetrician. Either a registrar or a consultant will come and they will do the delivery. So the best thing to do in this scenario is just push the cord back. If you're a junior doctor assisting with the delivery, you find a cord, patient fully dilated, you make sure that the cord is warm in a warm area within the vagina. And then you press the first button and start the maneuvers. What's the maneuver? Let's go through them one by one. Because baby is in distress clearly. So this needs to be done very, very quickly because it's an emergency now. As there is a cord prolapse, so baby can go into distress anytime. Pushing cord is on both stages. So you don't want the cord to be exposed at the moment. You need to just push it back. And then what we do usually is call the senior obstetrician, midwife, pediatrician, and then we arrange the mom in deep knee to chest position on left side, elevate the presenting part of the cord, minimize handling of the cord, and then once everyone is in the room, then we prepare for the instrumental delivery. Because we don't want the mom to push at this stage. Okay. Are you guys able to see the screen at this point? Okay. So our mom had second stage of labor because +2 plus dilatation. So if presenting part is at or below spines, aim for immediate vaginal birth. Prepare for instrumental birth if appropriately trained doctor is there. If there is no doctor is there, then we encourage the mother to push vigorously to facilitate spontaneous birth. If you can't do an immediate vaginal birth, then you need to organize an emergency section. What do we do if there is first stage of labor? Aim for immediate birth through the C-section. So we don't aim for vaginal birth. Oxygen through the face mask, IV access, group and safe, continuous CTG until birth, cease oxytocin infusion because we need to stop the uterus from contracting. Reduce the risk of cord compression until birth. This is done in both the stages. Place the woman in deep knee chest position. Make sure that the patient pelvis is flat and there is more space in the pelvis. Left-sided so that blood to the baby is not compromised as the patient is having the fetal heart rate drop to 95. That is a very concerning sign. Manually elevate the presenting part, minimize it, cord hardening. Consider tocolysis in the first stage, not in the second stage. Consider bladder filling. If cord prolapsed outside vagina, gently place it in the vagina or cover with the pad soaked warm saline. All of them need a neonatal resuscitation. Trained pediatrician should be there. Just going to mute all of you. It just causes a lot of disturbance. Sorry about that. If you have questions, I would really appreciate if you can just pop it in the chat box. Or after we have discussed, you can just ask me by unmuting yourself one by one. Neonatal resuscitation is required because cord prolapse is fetally distressful. And this baby will either be having neonatal observation plus minus nursery admission. If the baby if we can't go towards the C-section as early as possible in the first or the second stage, we need to take the arterial and venous cord blood gas samples to assess the oxygen level for the baby. This is very traumatizing for the mother. So after the birth of the baby, we need to organize a psychological psychosocial support for the mother. Risk for the cord prolapse, causes of the cord prolapse, management of it. Every obstetric emergency, I always suggest my students to go through SA Health Guidelines. They have beautiful flow charts. So if you don't even want to read the whole topic, just these flow charts would be enough for you for your exam. So very comprehensively written. The amount of information here is excellent. You can solve each and every one of your questions associated with the obstetric emergency from here. It's very comprehensively written. So this is the position we usually ask them to make. It facilitates and opens up the pelvis diameter a lot. Okay, what else? There are special trainings in the hospital, especially in the obstetric department for the midwives as well, to manage a cord prolapse if there is no senior obstetrician or a trained obstetrician is there. There are also midwives are also trained as well. So because it needs to be done very quickly if the ongoing supporting staff is not available, or if there's a delay of them getting to the place to help the mother and the baby, the midwives step into the role and they do the assisted delivery as well. Nowadays, they are trained, they have special certification they have to do, and they are trained here as well. All right, next question. Sorry about this. There are two husbands. There is male sex partner to a male. One is HIV positive and one on the treatment. Partner is HIV negative. What recommendations for the partner who is HIV negative would you give? Barrier method, do every sexual intercourse, prolonged HIV prophylaxis, avoid anal recipient intercourse. Excellent. So the best way to prevent HIV is to avoid secretion exchange, especially seminal secretion exchange. So for homosexual partners, we always counsel them about using barrier method. Condoms are 99% effective in preventing the transmission of the HIV unless it breaks during the intercourse. There is no such thing as prolonged HIV prophylaxis. There is a certain period of time for HIV prophylaxis, and it's a pre-exposure prophylaxis. So if it's a HIV partner positive and is on treatment already, then the partner should receive HIV pre or post-exposure prophylaxis, depending upon their situation. There is no prolonged HIV prophylaxis. Avoid anal recipient intercourse is not a good advice to give. You just safety net them about not exchanging the fluids, especially the seminal fluids. That is the main transporting agent for HIV infection. So barrier method is very effective in that. Excellent. Regarding the sexually transmitted infection, there is a STI guidelines Australia. They have provided information about each and every sexually transmitted infection. It's a very comprehensive situation to start pre-exposure prophylaxis. So pre-exposure prophylaxis is, Dr. Gayatri, for example, a hepatitis B patient, you're treating them in the hospital, you know it's an active hepatitis B patient or a HIV patient, and the patient has been pricked, the doctor has been pricked while taking the blood of the patient, then you need to give post-exposure prophylaxis to that patient. Pre-exposure prophylaxis is given to those patients who are getting into a consensual relationship with the person who is in infective state. So before you do the exposure, you give them prophylaxis to prevent any transmission. So condoms is a kind of pre-exposure prophylaxis. It prevents the patient to become exposed to the agent that might cause disease in the said patient. Okay, let me just show you the question again, and then we need to quickly go. Yes, Dr. Athia, you have given a big line. What's up? This is the question again, Dr. Sidra. If you're done, I'm gonna move on to the guidelines. Okay, so STI management guidelines, Australia. Partner is already exposed, so post-exposure prophylaxis, not prolonged HIV prophylaxis. And to prevent them from getting exposed every day, condom is like a pre-exposure prophylaxis as well. Does that make sense? So any STI transmission, if the partner is unaware of the disease, then we give them post-exposure prophylaxis once they have the transmitted agent inside the body. To prevent the disease agent getting to them, we do the pre-exposure prophylaxis. Does that make sense? So safety netting on both ends. Okay. We know about HIV. It causes acquired immunodeficiency syndrome, variable period. There is an incubation period as well. It's not necessarily that every HIV causes AIDS, but it can cause AIDS in a patient who has a trigger or or is undergoing an immunocompromised state. So the treatment is that we give antiretroviral therapy, which is lifelong, and our aim is to make sure that CD4 T cell count comes up and the viral load goes down. In this manner, the partner is no longer infective or undetectable or untransmissible, and they have normal life expectancy. Cause we know HIV is a retrovirus, RNA virus, clinical presentation that it can cause acute infections like fever, rash, lymphadenopathy, jaundice, pharyngitis, myalgia, diarrhea. Very common is fever, lymphadenopathy, and diarrhea. So any patient who has traveled has encountered unprotected sexual intercourses, especially in homosexual population. We need, if they are presenting to you with fever, rash, lymphadenopathy, diarrhea, or sore throat, please always screen them for the sexually transmitted infection. Asymptomatic infection can then occur for several years following infection. Immune deficiency is related to them because of the CD4 T cell count lowers, and then patient can have opportunistic infections like candidiasis, pneumocystis, Jervosi pneumonia, PJP, a cerebral toxoplasmosis, cancers like Kaposi sarcoma. Post-exposure prophylaxis. So if a patient gets exposed to HIV-infected patients, so we need to offer it to them within the first 72 hours of the exposure. Painless, not painful. Painless. If the word prolonged was not there, still we select condoms as first. So if prolonged is not there, then yes, I would agree with you, Dr. Gayatri. HIV prophylaxis, post-exposure or pre-exposure, depending upon whether the patient has exposed to the partner that he is HIV affected or not. Diagnosis, we know that it's a serological test we do. Prevention is post-exposure for prophylaxis and pre-exposure prophylaxis. Management is the retroviral therapy and this one. So in this patient, if the partner hasn't exposed that he was HIV positive and exposed the partner, then within the first 72 hours of informing the patient and having unprotected sexual intercourse, you need to provide the therapy. Also, in these patients, if they want to be in the consensual relationship lifelong, you need to advise them about the pre-exposure prophylaxis as well. Do the STI testing for other sexually transmitted infections. Special consideration is that patient who have co-infection, you may need to treat them with for hepatitis B and C as well. Pregnancy doesn't matter. Pardon me. It doesn't matter if a patient is pregnant or not. You need to start the antiretroviral therapy because in pregnancy, it can be transmitted to the baby through the vaginal birth. So we avoid the vaginal birth as well and breastfeeding as well. And aim is that we need to keep these cells up. If the patient have a low count of this, we need to give them prophylaxis like for PJP. For PJP prophylaxis, we give trimethoprim sulfamethoxazole every week for at least 3 months or 6 months or fortnightly, and also we need to give prophylaxis for fungal infections like chlorotrimazole or fluconazole. Contact tracing, very important. And every contact should be given post-exposure prophylaxis. Follow-up is also very important because these people require social support as well. It's mentally very draining for these patients. All righty. Clear, guys? So they have everything. STI guidelines has every sexually transmitted infection written in detail about their cause, clinical presentations, what investigations to do, how to treat them, special considerations. So just go through that. 55-year-old farmer is presenting with left eyelid fossa mass. Fecal occult blood test is negative at 50, but still having weight loss, fatigue, on and off constipation. Next best modality to investigate, CT abdomen or colonoscopy. So we all know what this patient is having signs and symptoms of. Cancer. Which cancer? Colon cancer. So first, do we do colonoscopy or CT abdomen? Very good. Always remember, guys, if a patient is presenting to you with signs and symptoms of colorectal cancer, always do colonoscopy. Always do colonoscopy. Then we can do the staging by doing CT abdo pelvis chest. But CT scan is not going to give you any information if you can't see intraluminal cancer. So CT is not the best option to go for. Next best is colonoscopy. Yes, they are asking about next best there. It is colonoscopy. We do colonoscopy first. We do CT, abdo, pelvis, and chest later. We don't do it. We don't do imaging modality first. For colorectal cancer, colonoscopy is the best modality of investigation. We can see the cancer if it's there. We can see protrusion of the cancer, because or we can see initial test, fecal occult blood test. If a patient is presenting to you with weight loss, on and off constipation, light eyelid fossa mass, do full blood count, urea electrolytes, creatinine, iron studies, and fecal occult blood test. Even if fecal occult blood test is negative, do colonoscopy to rule out colorectal cancer. Is it clear? All righty. You guys can go through this or this one as well. I'll show you guys one of these. Okay, even if you look over here, okay. I'm not gonna go into the big detail of the guideline. Even if you look at this flow chart, that will be enough. Home. Okay, blank. It's not coming up nicely. Okay, look over here, guys. If the patient is having symptoms of colorectal cancer, diagnostic studies. What are the diagnostic studies? Colonoscopy, sigmoidoscopy. Okay, look at this one as well. No, it's not clear. Let me just copy it and paste it. Maybe it will come up nicely here. Okay, it's coming up nicely. Look at this one. Rectal cancer, colorectal cancer, doesn't matter. Initial evaluation is colonoscopy, biopsy of the lesion, histopathological review. That is done for all colorectal cancer. Doesn't matter, it's just rectal cancer or not. Metastatic evaluation, then you do chest, abdomen, pelvis, CT scan, CEA levels, liver function test, endorectal ultrasound or endorectal pelvic MRI to diagnose the extent of the disease and plan surgical management, and PET scan of the body. Pre-surgical evaluation is digital rectal examination, proctoscopy, or indication for whether we need to do a fecal occult blood test or not. Is it clear, guys? So we don't do imaging first. We do colonoscopy, sigmoidoscopy first. Sorry. My throat is closing up a lot today. All right. 10-year-old boy is on stimulants for ADHD, but he is non-compliant, causing problems in school, not listening. First is fecal occult blood test. If you are screening a patient or if a patient is having symptoms of colorectal cancer and you're very suspicious, do fecal occult blood test, full blood count, iron studies, and then refer the patient for colonoscopy. So 10-year-old boy is on stimulants for ADHD, which is attention deficit hyperactivity disorder. He's non-compliant, 10-year-old. And because of that, he's having problems in school, not listening to the parents as well. What do you want to do? Involuntary admit the patient? Talk to the boy about the advantages and disadvantages of the drug, which is the cognitive behavioral therapy. Talk to the parents to insist on giving medication or ignore the prescription. So we know we don't do A, we don't do D, which is not helpful to our patient. 10-year-old boy, very much required that we talk to the boy about the advantages and disadvantages of the drug. It is education to the child. And then the next step will be the education to the parents as well. So it's a B plus C thing, but B should take place first. 10-year-old boy are not so young. They do have some knowledge. So if you break it down in simple terms about why they should have the medication in the presence of the parent, you are educating both of them together. So education about the medication to both the patient and the parent is very important in this case. If the child was very young, then option C would have been much correct. But here, 10-year-old child is able to understand you. They do have ability to understand what's happening to them. So option B would be much correct in this. You guys can read the whole topic from there, but they have written B and C together. From my experience by working in the hospital and from day-to-day managing of the pediatric cases, this age group, 10, 12, 13, not 10, but 12, 13 also comes under Gillick competence. They have some ability to understand. So do explain it to them in the presence of their parents about the advantages and disadvantages of the drug. Pharmacological education to the patients of the ADHD is very, very important. Otherwise, they won't. The non-compliance is the cause of them having more symptoms. All right. Next question. Patient is having aortic stenosis, 35 millimeter. Stenosis is there, and gradient pressure across the stenotic valve is 45 millimeter of mercury. What is the appropriate management? Do you do surgical repair or do you do balloon valvuloplasty? Okay. Look at this first, guys. This is from Heart Foundation, Australia. So they have given you information about when to do surgery for a patient with aortic stenosis. Now, aortic stenosis patient, we assess two things with the help of echocardiography. The first is the maximum velocity across the valve. Number two is the stenosis diameter. And then number three is the mean pressure gradient. These three will determine, along with the symptoms present or not of the heart failure. These three things will detect whether patient will have surgery or not, whether open surgery or transcutaneous aortic valve implantation, TAVI, which is basically known as. So if the patient is presenting to you with decompensated heart failure, you've done an echo, you found that he has severe stenosis, which is 35 millimeter is a severe stenosis, plus the mean velocity across the valve is more than 4 millisecond and pressure gradient is more than 40, then this patient requires urgent transfer to a tertiary care center where they can have aortic valve replacement. The other thing that you should be aware of is that when do we do balloon valvuloplasty? So well, in patients who can't have TAVI or surgical aortic valve replacement, you can do balloon valvuloplasty, or if there is moderate stenosis. But the problem with the balloon valvuloplasty, the outcomes they have compared in the, sorry about this, guys. They have compared the outcomes of both the surgery over the period of 5 years. The patients who had balloon valvuloplasty had the same benefits immediately after this surgery as compared to the TAVI or as AVR. But at some point, their stenosis became recurrent and they need to have TAVI. So it can be one of those things that you need to remember, that with balloon valvuloplasty, the aortic stenosis can happen again. But once you replace the valve, there's a chance less likely for it to come back. So here, the best option will be surgical repair either through open surgery or through TAVI. This is a very good flow chart that you guys can go through. It's taken from CardioGuide aortic stenosis. I'm not going to go into full detail of that. You guys can take a screenshot of this. But if you want, if you study this, you'll be able to understand why we are talking about the velocity, mean pressure gradient, and the symptoms present there or not, and why we do an echocardiography for them. Once we have confirmed there's aortic stenosis, we have to do a CT TAVI, in which we gate the aorta and the aortic valve in such a way we can see whether the patient is able to provide or survive the surgery, or what kind of valve thickness or valve replacement would they require. The link is here, guys. Take a screenshot. Okay. Is it clear, guys? Any questions from aortic stenosis? It's a wonderful topic. Very easy to understand as well. There is basically what I have talked about. These three things you should keep in mind when we are talking about sending a patient or talking about getting a workup done for a patient who requires valve replacement. Another thing you need to remember is that a patient who had problems with the dental problems, they will have postpone of the aortic surgery or valve replacement because there is a dissemination of the bacteremia from the dental perspective into the aortic valves. So make sure they have a dental appointment before they are sent for the surgery. There is a patient postoperative. He's on percutaneous analgesia with the fentanyl. It's like a line into their skin, and they press a button and they and the machine administer a specific amount of the analgesia. Patient is feeling very nauseated, but not complaining of any pain. What do you want to do next? Change the drug, reduce the dose, Tramadol and diazepam or give antiemetic? So patient is complaining of nausea. What's the first thing that you want to do? We need to treat the nausea. And what is the second thing you want to do? What can be contributing to nausea as well? Stop the cause. What's the cause? It can be associated with the fentanyl as well. So treat the nausea first and then reduce the dose and see if the patient symptoms subside or not. Because the cause can be fentanyl as well. So treat the symptoms and prevent the cause. Very good. Next is the similar one, but in a different way. Labor was progressing normally and 5 centimeter dilatation. Station is +1. All fetal parameters are normal. You saw or felt a pulsating cord in the vagina. Most appropriate next step, reduce the cord, increase oxytocin, or go for surgery. Not necessarily, Dr. Mujib. Metoclopramide is also antiemetic. Okay, very good. Your answer is absolutely correct. Now, I'm just going to change it a bit. What should be your answer now? Excellent. Excellent, Dr. Mark. Excellent, Dr. Sanjita. Dr. Harrison, excellent. So as we discussed previously through the flow chart, if the patient is in first stages of the labor and you see a pulsating cord in the vagina with the normal parameters, then most appropriate step is that we deliver this baby through the emergency cesarean section. And the next step would be to minimize the handling of the cord, make sure it's as up as possible, make sure that it's not exposed to the air. What was the answer to the previous question? We gave metoclopramide to stop the nausea, and then the next step would be then, other than the metoclopramide, the next step would be to reduce the dose. So in this case, cesarean section we do, but if it's like full dilatation +2 station, fetal heart rate is decreasing, assisted vaginal delivery after the maneuvers. Clear, guys? Okay. I should have put the questions together. Okay, there is a mass in the picture, if you can see. Patient is complaining of fever, night sweats. There is smoking history as well. The lump by fine needle aspiration and cytology is malignant. You have done a chest x-ray and sputum culture and microscopy. What do you want to do next? Sputum cytology again, Montauk's, CT head and neck, or bronchoscopy? Okay, someone said bronchoscopy. We don't do bronchoscopy in the neck masses. There's no indication of it. Bronchoscopy is done for lung mass lesions which are near the midline. So we need to do CT head and neck to know the extent of the cancer. Very good, Dr. Frank. Most of the time, the guideline which is followed in Australia regarding the adult neck masses is that we do CT head and neck first, and then fine needle aspiration and cytology. But here they had already done a fine needle aspiration and cytology, which showed you a malignant mass, followed by chest x-ray and sputum culture and microscopy. The next step we need to do is find out whether this mass is primary source or secondary source. So CT head and neck will help you in that. Now, they try to confuse you with the tuberculosis diagnosis if it's there. So don't get confused. They have mentioned with fine needle aspiration and cytology, it's a malignant tumor. So don't go for sputum cytology. But if it is nothing fine needle aspiration and cytology, there is patient is complaining of fever, night sweats, maybe having a neck mass, coughing, have a travel history, then we do 3 sputum cultures, chest x-ray, and depending upon that, we treat the patient with tuberculosis. Adult neck masses, we do CT head and neck. Yes, Dr. Nuda, but in kids, we do ultrasonography. That is absolutely correct. So this is the guideline we follow. Oh, same. So adult neck mass, if there is no infectious symptoms, then we need to perform targeted examination, obtain CT of the neck, followed by fine needle aspiration and cytology. If the diagnosis is not obtained, then we go for biopsy, but we don't do bronchoscopy in them. Clear? And this is for tuberculosis. If there are symptoms of tuberculosis and active symptoms are there, then you need to do a chest x-ray with 3 sputum samples, microscopy as well, and molecular assay. And depending upon that, we start the patient on the appropriate drugs. Yes, if there is no information about fine needle aspiration and cytology stating it's a malignant mass, it could be a tuberculosis case. So in that way, I would suggest you guys 3 sputum samples, chest x-ray, IGRA, if it's a latent PB, or TST. TST is not usually performed. IGRA is actively performed. All right. Next question, guys. Any queries? Yes, gene expert is there. We do it very regularly. We sometimes skip sputum cultures, but gene expert is done. It's regularly done in patients with which we suspect there is latent TB. Woman comes in after one woman comes in a week after 2-year anniversary of mother's death. She's tearful. She says she sees the mother a lot in her dreams. And one night she actually saw her mother standing in the doorway. It was as if she was really there. What symptoms she is exhibiting? Major depressive disorder, bereavement, schizophrenia, or adjustment disorder. So we all know, very easy question. This is bereavement, or complex grief can be there as well. It's not PTSD. PTSD is different. This is more grief associated. So bereavement or complex grief, we can say. Have a look at this chart. It will give you an idea. They have many symptoms overlapping, but most of the time, grief has loss of family member. Somebody, there would be some history of somebody dying. There will always be a history of that in bereavement or grief or complex grief. And they can have overlapping symptoms as well. Depression doesn't need somebody to die to happen in a patient. It can happen in anywhere. It can happen anytime. All right. Next question is that there is a trauma to your eye and there is blood in the anterior chamber. What do you do while waiting for the ophthalmology referral? What would you suggest to the patient as a general practitioner, for example? Eye patch, eye drops, antibiotics, or bed rest? So I would suggest you to look for option 5 as well, because in patients of eye trauma, we suggest option 1 and option 4 together. So we would ask them to wear an eye patch so that there is no further trauma, and we would ask them to bed rest so that they don't bump into things and cause major damage to their eyes. So look for option 5. If it says option 1 and 4, that is the correct answer. Does that make sense, guys? So we don't want this patient to have further trauma to the eyes. To prevent that, we advise them about patching the eye and bed rest as well. Yes, I agree. It's bleeding, so patch would be better. But if the patient is moving about, it's bleeding. So moving about doesn't help. It can worsen the bleeding as well. So both the things is required. If you look over here, so bed rest, eye shields, sufficient. You can walk around with an eye patch, but it's recommended because it's self-limiting and you don't want it to progress. That's why we ask them to wear eye patches and bed rest, restrict the activity to prevent further bleeding. It's class 1A recommendation for the patient with hypema. You don't want them to bleed again. So strict bed rest with eye patches is recommended. And sometimes elevation of the bed also helps because you want the blood to pool at the bottom of the anterior chamber and heal itself. If there is ongoing bleed or the hypema is increasing, then it's an urgent referral. If it's the tiny one and you think there is no risk factors for bleeding, rebleeding, then it's self-limiting. Sorry about this. My throat. Apologize. There is a young girl. She's complaining of dysphagia, worse with solid than liquid. There is history of eczema. What investigation would you want to do? They haven't mentioned initial or best. So barium meal and esophagoscopy or CT scan. Very good, Dr. Majid. We are looking for eosinophilic esophagitis, and the best way to do that is not barium meal. Barium meal is not going to tell you about anything. The history of eczema is giving you a clue that there is allergy factor involved. Most likely the diagnosis would be eosinophilic esophagitis. So you would do esophagoscopy, which will show you concentric circles. Let me just show you what eosinophilic esophagitis looks like on images. Where is it? Oh, look at this. There's a very good picture here. This is what it looks like on esophagoscopy. So there will be concentric circles, like it almost exactly looks like a trachea. Very good, Dr. Frank. It looks like there's a trachealization of the esophagus. So esophagus looks like a trachea because of the concentric circles. Alrighty, so esophagoscopy is the best modality to diagnose it, other than the blood test showing you eosinophilia. So there's different types of dysphagia. We all know about it. There's oropharyngeal, and then there's esophageal, levels of it. So it can be structural, it can be neuromuscular. So structural it can be because of the carcinoma. There is a diverticuli present. Eosinophilic esophagitis can cause structural abnormalities. Rings can develop. Lower esophageal sphincter rings and strictures can develop long-standing to GERD. Neuromuscular can be present like achalasia, esophageal spasm, hypertensive lower esophageal sphincter, or something secondary to long-standing GERD, scleroderma. And oropharyngeal can be structural, but it's very, very common as neuromuscular disorders like Parkinson's, stroke, myasthenia gravis, multiple sclerosis, tumor. If it's an older patient, we can think about cancer. Yeah, definitely. If it's an older patient complaining of weight loss, fever, night sweats, associated progressively worsening dysphagia to solids, and then again to liquids as well, you should have the first thing you want to rule out, it should be cancer. Last question of the evening, guys. 35-year-old female has a history of total abdominal hysterectomy with bilateral salpingo oophorectomy. There is no history of breast cancer or other diseases. She's coming to you with her DEXA results. I think we discussed in the last trial class about this. T-score is minus 2.5 spine and minus 1.5 femoral. In addition to giving her calcium, how do you treat that? Give her bisphosphonate, hormone replacement therapy, cyclical estrogen or progesterone, or only estrogen replacement. We discussed that in the last class, guys. So young patient coming to you with osteoporosis, had surgically induced menopause. What do we treat? How do we treat the osteoporosis? Come on, guys, we discussed that. No, we don't give bisphosphonates. It's a surgically induced menopause. What do we need to do? Give hormone replacement therapy. We need to give hormone replacement therapy. We discussed it in the last trial class. Look, it's a very young female, had total abdominal hysterectomy with bilateral salpingo oophorectomy, surgically induced menopause. There is no menopause that happened naturally. It's surgically induced because of some condition she had, right? She is young. She is now deficient of her normal hormones to prevent osteoporosis, osteopenia, and to treat that. So now she is coming to you with signs and symptoms and the evidence of osteoporosis. In this case, young patient, surgically induced menopause, you treat the osteoporosis with hormone replacement therapy, not the bisphosphonates. Once she is menopausal, you can stop the hormone replacement therapy and start the patient on bisphosphonate. That is what we do. So primary treatment for her is hormone replacement therapy. So hormone replacement therapy will not only prevent osteoporosis, but will give her a normal hormonal balance in the body for the functions as well. Giving her hormone replacement therapy plus bisphosphonates will be much beneficial rather than just putting her on bisphosphonates. We can continue with hormone replacement therapy after menopause. After menopause, if it's a normal menopause, then hormone replacement therapy has indications to be started if the patient has postmenopausal symptoms. If it's a surgically induced menopause in a young patient, we need to give her hormones nonetheless to survive the rest of her life, because estrogen and progesterone are required for normal body functions other than reproduction as well. It's a metabolic hormones, right? So for the treatment of osteoporosis, these hormones are also required. They will prevent osteoporosis progression. Once you have established them on HRT, you can start them on bisphosphonates as well. Is that clear, guys? That makes sense? When will we start this patient with bisphosphonates? After you have established the patient on the hormone replacement therapy, you can start the patient on bisphosphonates. Yeah, how HRT? It will prevent further osteoporosis. It will prevent further osteoporosis. So start the HRT first, because that is the thing that is causing the osteoporosis in this patient. That is the pathophysiology of osteoporosis in this patient, is the lack of hormones. So give her hormones and start her on bisphosphonates so that the bone can be remodeled and built up again. Nothing will happen. We just need to monitor her because she doesn't have any breast cancer history or other diseases, which is a contraindication for HRT. Once we start her on HRT, she can have normal. Yes, 45-year-old postmenopausal women's osteoporosis treatment is bisphosphonate. Yes, 45 normal postmenopausal female osteoporosis treatment is bisphosphonate. That is absolutely correct. No, start the HRT and then bisphosphonates. So we have to stop HRT and 45-50, then have to start bisphosphonate in this case. No, you start HRT, then bisphosphonates at normal menopausal 8, stop the HRT, continue the bisphosphonate if required. Is this correct? Is this clear, guys? 47 slide. This one. Is there a cutoff margin? Cutoff margin for what? Sorry, guys. I don't understand your question. Okay, you guys can study it from here. I'm way past my time. So, surgical induced menopause. Study it from here. It will make it much more correct, easy to understand. But the basic crux is that young patient, surgically induced menopause, HRT, then bisphosphonates, postmenopausal female with osteoporosis, bisphosphonates is the first line. All right, guys, that's about it for today. Sure. Which one do you want to take a screenshot of? This slide? We don't have a Telegram group, but we do have a Facebook group. So if you have any queries, then do let us know. And I hope I will get to see all of you guys in the coming course session. So do let us know if you're about to join our class. You will find it's much beneficial for you for passing your exam. You need to ask that about with Dr. Arshan. All right. Thank you so much, guys. I hope you had a great session. I enjoyed a lot. So don't get worried about the exam. The information is there. You just need to revise it. And that's what you usually do throughout your whole career as a doctor. You need to re-revise your information so that you're doing justice with your patients. Thank you so much for joining our class. I hope to see you guys in the course. If not, then best of luck for your exam. Thank you. Take care.